Good afternoon, everyone. Today I'll be talking about drugs used for cough. So, what is cough? Cough is a useful physiological mechanism that serves to clear the respiratory passages of foreign material and excess secretions. So, it is a cough reflex is a complex involving the central as well as the peripheral nervous systems as well as the smooth muscle of the bronchial tree. So, it is a complex process involving the central as well as the peripheral nervous system as well as the smooth muscle of the bronchial tree, and ideally it should not be suppressed indiscriminately. Chronic cough can contribute to fatigue, especially in elderly patients, and in such situations the physician should use a drug that will reduce the frequency or intensity of coughing. So, not all cough is harmful, but only when it contributes to certain debilitating conditions, then we can think of using drugs for cough. It has been suggested that irritation of the bronchial mucosa causes bronchoconstriction, which in turn stimulates cough receptors, which probably present a specialized type of stress receptors located in the tracheobronchial passages. So, when these cough receptors are stimulated, then we get the stimulus of cough. So, for the treatment of cough, the drugs that directly or indirectly can affect this complex mechanism are diverse. For example, cough may be the first and the only symptom in bronchial asthma or allergy, and in such cases other drugs, not specifically drugs for the cough, but other drugs such as bronchodilators, for example beta-2 adrenergic receptor agonists, have been shown to reduce cough without having any significant central effects. Other drugs act primarily on the central or peripheral nervous system components of the cough reflex. So, we will be having a different class on drugs for bronchial asthma, but the cough in bronchial asthma can be reduced by use of beta adrenergic receptors agonists, and so it is not a specific for cough, but it is through the other mechanisms. So, what is the mechanism of cough? First is stimulation of mechano or chemoreceptors, which are present in the throat, respiratory passages or stress receptors in the lung. So, there are different receptors, mechanical as well as chemoreceptors, which can be from the throat, the respiratory passages or the stress receptors in the lungs, and sometimes even the GI tract. The irritation of the GI tract can also cause cough. So, from these afferent impulses go to the cough center, which is located in the medulla, and then the efferent impulses via parasympathetic and motor nerves to the diaphragm, intercostal muscles and lungs, and then it causes increased contraction of diaphragmatic, abdominal and intercostal muscles. So, this leads to noisy expiration or the cough. So, this is how a cough reflex happens. The cough receptors can be both chemo as well as mechanoreceptors. They lie in the mucosa of the bronchial tree from the nose to the distal bronchi. The impulses from these receptors are transmitted through the vagus and the glossopharyngeal nerves to the cough center in the medulla. So, the cough the nerves, different nerves like glossopharyngeal nerves, even trigeminal nerve or other nerves will transmit the impulses from the cough receptors to the cough center in the medulla. So, this is a diagrammatic presentation of the different cough receptors present over the respiratory passages and through the vagus nerve, the phrenic nerve, the trigeminal nerve, the glossopharyngeal nerve. So, all these will transmit to the cough center in the medulla, and then the cough reflex will evolve. So, two major types of coughs are productive cough and non-productive cough. These are the two basic classification of cough. In other way, cough can also be classified as acute, which occurs for less than 3 weeks, subacute, which can occur anytime between 3 to 8 weeks, and chronic, when the cough lasts for longer than 8 weeks. So, this is a classification of acute cough, subacute cough and chronic cough. What are the common causes of cough? It can be common cold, upper or lower respiratory tract infections, allergic rhinitis. Smoking can also precipitate cough, chronic bronchitis. A common symptom of chronic bronchitis is cough. Even pulmonary tuberculosis. Many patients of pulmonary tuberculosis present to you with chronic cough lasting for more than 1 or 2 months. Asthma patients can also present with cough. The gastroesophageal reflux disease patients can also present with cough because the reflux causes irritation of the respiratory passages, and so it can also present as cough. Pneumonia, congestive heart failure patients, bronchiectasis patients can also present with cough. And certain drugs can also precipitate cough. For example, The angiotensin converting enzyme inhibitors like captopril, enalapril, all these can precipitate cough as a side effect, and other drugs are also there like even beta blockers and amiodarone, they can precipitate cough. So the drugs used for cough can be divided into antitussives which prevent cough like opioids, non-opioids and antihistamines, the expectorants which will help in propulsion of the sputum, which can be secretion enhancers or mucolitics, and pharyngeal demulsions. These are the soothing agents which will decrease the irritation in the pharynges or the throat. So these are the major classification of the drugs used for cough. So the pharyngeal demulsions examples include lozenges, cough drops, linctuses containing syrup, glycerin and licorice. The expectorants are the drug that enhance the secretion of sputum. So they can be mucokinetic, that means they increase the bronchial secretion. So the mucokinetics are bronchial secretion enhancers. Examples include sodium or potassium citrate, potassium iodide, guaifenesin, ammonium chloride, etc. And they can be mucolitics like bromhexine, ambroxol, acetylcysteine and carbocysteine. So the expectorants can be mucokinetics or mucolitics. The mucolitics, they decrease the viscosity of the mucus. The antitussives are basically cough center suppressants. They are the drugs that suppress coughing, possibly by reducing the activity of cough center in the brain. So they are classified as opioids or non-opioids. The opioid example include the commonly used are codeine and folcodeine, and the non-opioid antitussives include noscoping, dextromorphan, clofeniramine. Certain antitussives, antihistaminics can also act as antitussives like chlorpheniramine, diphenhydrinate and promethazine. So these are also common component of your cough syrups. And adjuvant antitussives include bronchodilators. For example, salbutamol and terbutaline, which are used in asthma, they also act as adjuvant antitussives by their bronchodilating action. The centrally acting antitussives include narcotic antitussives like codeine, hydrocodone and oxycodone, and the non-narcotic antitussives include dextromorphan, noscoping and propoxypine. The peripherally acting antitussives include mucosal anesthetics like benzonatate, clofedianol, and some hydrating agents, even steam inhalation and aerosols can also help in acting as antitussive agents, and the miscellaneous like bromhexine. These are the classification of antitussive agents. So what is the mechanism of action of antitussives? The opioid antitussive agents, they suppress the cough reflex by acting on the cough receptor, cough center in the medulla. So all the opioid antitussive agents, they suppress the cough reflex by acting on the cough center in the medulla. The non-opioids, whereas they suppress the cough reflex by numbing the stress receptors in the respiratory tract. So they cause numbness of the stress receptors present in the respiratory tract and prevent the cough reflex from being stimulated. So that's how most of the non-opioid antitussive agents act. What are the indications of the antitussive medications? They are used to stop the cough reflex when the cough is non-productive. So these antitussive agents should be mostly used only for dry cough when the cough is non-productive. So I have already mentioned the examples of opioids like codeine and folcodeine, and non-opioids like dextromorphan, noscoping and piperazethate. Codeine, it suppresses the cough center in the medulla oblongata. It is well absorbed from the oral as well as the injection, and 10% is converted to morphine through demethylation. And as I told you before, antitussives should only be used for dry coughs, and so codeine is used for dry cough. It is a semi-synthetic opioid analgesic. It is a potent cough suppression. It has potent cough suppression action, and it is given as 10 milligram BD or thrice a day, or in lesser doses. There can be addiction or constipation, and overdose can result in, because it is an opioid and opioid class of drug, it can cause respiratory depression, and overdose can also result in convulsions, postural hypotension and tachycardia. There can be shortness of breath, sedation, euphoria, allergic reactions and constipation. So morphine and methadone, they are indicated only for intractable cough associated with bronchial carcinoma, because they are strong opioid agents, and so they are indicated only for intractable cough associated with bronchial carcinoma. Folcodeine is structurally related to codeine. It is more potent, longer acting and better tolerated than codeine. It causes lesser constipation, which was more common with codeine, and drowsiness than codeine. So, compared to codeine, folcodeine will cause lesser constipation and drowsiness, and it is given orally in doses of 10 to 15 milligram twice a day. Dextromorphan, it is a methyl ester of dextroisomer of liverphenol. Mechanism of action is, it is considered to be an NMDA receptor antagonist and methyl D-aspartate receptor antagonist. It has least addiction potential and no analgesic action. Unlike liverphenol, it has least constipating effects and minimal drowsiness. So, it is as potent as codeine. It is used in a dose of 10 milligram 3 times a day. It is used as a cough suppressant used for temporary relief of cough caused by minor throat as well as bronchial irritations. The adverse effects include nausea, vomiting, drowsiness, dizziness, blurred vision, slow breathing, confusion, hallucinations, anxiety, restlessness, and nervousness can occur in high doses. So, dextromorphan, it is considered as an NMDA receptor antagonist, and it has least addiction, no analgesic action, and least constipating effects and minimal drowsiness as compared to codeine. Noscoping is naturally occurring opium alkaloid belonging to benzyl isoquinoline group. It is also devoid of analgesic activity, drowsiness and liability or addiction potential, has minimal constipating effects, and it is a popular cough suppressant. It is given orally in a dose of 15 milligram 3 times a day. However, it can produce headache and tremors. So, it is useful in spasmodic cough, and it can also cause release of histamine and cause bronchoconstriction in asthmatics. So, you should be careful when you prescribe a cough remedy containing noscoping in asthmatic patients because of the potential of bronchoconstriction in such patients. Pipazitat, it is a phenothiazine group of antitussive occasionally used in cough mixtures. It has negligible CNS depression effect. It is used orally in a dose of 40 milligram 3 times a day. Morphine is a powerful cough suppressant, but long-term use can cause constipation and other side effects of morphine. So, it is not very commonly used in cough preparations because of its addiction potential and misuse potential as well. So, other central and peripheral antitussives include it is like benzonatate. It is an antitussive structurally related to the local anesthetic tetracaine. It inhibits the afferent cough impulses to suppress the central cough center, but it also inhibits pulmonary stress receptors located in respiratory passages, lung and pleura. So, therefore, it has benzonatate has both central as well as peripheral mechanisms of action. So, it also acts inhibits the afferent cough impulses to suppress the cough center in the medulla, and also inhibits the pulmonary stress receptors located in the respiratory passages, lungs and pleura. It possesses mild local anesthetic action, and it is given orally in a dose of 100 to 200 milligram 3 times a day. The side effects include dizziness, drowsiness, nausea, dysphagia or difficulty in swallowing and headache. Seizures and cardiac arrest have been reported after acute ingestion of this agent, and severe allergic reactions may occur in patients allergic to PABA, a metabolite of this drug, because this drug is converted to PABA, and those patients who are allergic to PABA can develop severe allergic reactions. Coming to the next class of drugs, that is demulsions. They are indirectly acting cough suppressant. They do not have a cough suppression action of their own, but they are indirectly acting cough suppressant. They provide protective coating over the sensory receptors on the pharynx or the throat. So, they prevent the sensory nerves from being activated or sensitized. Examples include honey, licorice, lozenges, cough drops and glycerin. So, they have a soothing effect on the throat. Prenoxidazine, it acts by inhibiting pulmonary stress receptors to relieve bronchospasm. It has moderate antitussive action, and it is also given orally 100 to 200 milligram 3 times a day. So, demulsions are some of the local anesthetics can also be used as demulsions. For example, xylocaine, bupivacaine applied on the pharynx and larynx and decrease the sensitivity of the receptors. So, sometimes local anesthetics like these agents, xylocaine and bupivacaine, are used. Antitussives should not be used in cough associated with bronchial asthma or chronic bronchitis or bronchiectasis because of they may cause harmful retention and thickening of the sputum, and they may worsen the underlying conditions. So antitussives should not be used in cough associated with these conditions like bronchial asthma, chronic bronchitis or bronchiectasis because of the risks of harmful retention and thickening of the sputum. Now coming to the next class of drugs, that is expectorants. They increase the volume and decrease the viscosity of secretions to enhance the propulsion of these secretions upward and outward by ciliary movement and coughing. So they increase the expectorants, they increase the volume and decrease the viscosity of the secretions and thus enhance the propulsion of these secretions or the mucus upward and outward by the ciliary movement as well as by coughing. Drugs that either increase or decrease the viscosity of the respiratory secretions and facilitate their removal by ciliary action and coughing are called expectorants. This can be done either by their mucolytic or mucokinetic actions. So what are mucolytic expectorants? They alter the chemical characteristics of the mucus to decrease its viscosity and facilitate its removal by ciliary action or coughing. So they cause alteration of the chemical characteristics of the mucus to decrease the viscosity and thus facilitate its removal by ciliary action or coughing. Some of the examples of commonly used mucolytics include N-acetylcysteine, carbocysteine, methylcysteine, erdosine, bromhexine, ambroxol, and Dornes alpha. These are some of the examples of commonly used mucolytic expectorants. So the mucolytics, they reduce the viscosity of the sputum. The two common groups are called cysteine derivatives and DNases. The cysteine derivatives, they reduce the disulfide bridges that bind glycoprotein to other proteins such as albumin and IgA. Whereas DNase, they reduce mucus viscosity. They are highly purified solution of recombinant human deoxyribonuclease. These cysteine derivatives, they act as antioxidants, they reduce airway inflammation, and they are also used in COPD and asthmatic bronchitis as well as tracheostomy. Some of the cysteine derivatives include N-acetylcysteine, carbocysteine, bromhexine, and ambroxol, which is the metabolite of bromhexine. The DNAs, they act extracellularly and does not affect living materials. They improve lung function. They are particularly useful in patients with cystic fibrosis. For example, Dornes alpha. So this is an example of DNAs, and this is particularly useful in patients of cystic fibrosis, which is a genetic disorder affecting the lung and the GI tract. So the mucolytics, bromhexine, it is a synthetic derivative of basicine, which is derived from the alkaloid basicine and derived from Adhatoda vesica. The mechanism of action is thinning and fragmentation of the mucopolysaccharide fibers of the mucus, resulting in increase in volume and decrease in viscosity of the sputum. So they cause thinning and fragmentation of the mucopolysaccharide fibers and hence increase the volume and decrease the viscosity of the sputum. Another reason is acetylcysteine, which is a mucolytic that decreases viscosity of mucus by splitting the disulfide or SS bonds of the mucoproteins and thus leads to decrease in viscosity. So it causes breakage of the SS bond or the disulfide bond of the mucoproteins. This action is facilitated by alkaline pH of more than 7 and nebulization, it is given as nebulization in 3 to 5 ml of 20% solution, and the onset of action is quick and it can be used 2 to 8 hourly. So the mucolytics like acetylcysteine or Dornes alpha, they are used in cystic, apart from for cough, it is used cough associated with cystic fibrosis to decrease the viscosity of the sputum. In patients of chronic bronchitis, acetylcysteine is also used for treatment of paracetamol poisoning, and unlevel use includes the treatment of dry eyes. So N-acetylcysteine is also used for the treatment of dry eyes, particularly keratoconjunctivitis sicca as 5% acetylcysteine with hypermelose. So this is how it is used in dry eyes. So apart from cough, it is also used in cough of cystic fibrosis, chronic bronchitis, and treatment of paracetamol poisoning, and used for the treatment of dry eyes. The adverse effects include nausea, vomiting, and sometimes they can lead to bronchospasm in bronchial asthma. The carbocysteine has protected SH group and therefore cannot work through SH group and SS interchange, disulfide interchange. So it cannot split the disulfide bond of the mucus. Ambroxol, it is a metabolite of bromhexine. Mechanism is similar to bromhexine and useful, more useful in mucus, thick mucus plugs. And it is given as 30 milligram thrice a day. So this was about the mucolitics. Now coming to the mucokinetic expectorants. These expectorants stimulate the flow of the respiratory tract secretions by stimulating the bronchial secretory cells. That means that is to increase the volume and also by stimulating the ciliary movements. So the ciliary movements facilitate the removal of the mucus. So they stimulate the flow of the respiratory tract secretions by stimulating the bronchial secretory cells to increase the volume and stimulate the ciliary movements to facilitate their removal. Drugs are often emetics that are given in subemetic doses. These mucokinetics, they are often anti-emetic, often emetics that are given in subemetic doses. Gastric irritation may stimulate an increase in mucus clearance via reflex mechanism. So they can also stimulate GI mucosa and which in turn lead to increased respiratory secretion. Examples include ammonium chloride, sodium citrate, Glycol and Guaifenesin. So Guaifenesin is not approved in India and it is only approved in US. The essential oils like oil of eucalyptus, they provide mild expectoration by directly stimulating the bronchial secretory cells. Ammonium chloride, it is also a cough expectorant in various cough mixtures. It causes gastric irritant and so it causes reflex bronchial secretion. And sodium citrate, it is conventionally used in several cough mixtures. After absorption, citrate gets converted to bicarbonates in vivo and the mucus becomes less viscous. So they increase the quantity of the mucus and they become less viscous and they also increase the mucociliary clearance. Glycol and Guaifenesin, they are obtained from curacao wood. They are safe expectorants with proven efficacy. Guaifenesin is less irritating derivative of Glycol. After absorption, they are secreted into the bronchial glands and increase their airway secretion and mucosal ciliary activity. So they act as mucokinetic agents. Orally, it is given in a dose of 100 to 200 milligram 3 times a day. Some of the other drugs used for cough include antihistamines. They are either to antitussives or expectorant formulations. Due to their sedative and anticholinergic actions, produce relief of cough, but they lack selectivity for the cough center. So they act as an adjuvant to the cough mixtures, but because of their sedative and anticholinergic actions, they produce relief in cough, but they are not selective for the cough center. They do not have expectorant action, but however they decrease the secretions in the tracheobronchial tree because of their anticholinergic effect. They are suitable for allergic cough and not for asthma. Examples include chlorpheniramine maleate, diphenhydramine and promethazine. These are the common constituents of cough medications in cough syrups or something. They are antihistaminics, first generation antihistaminics like chlorpheniramine, diphenhydrinate and promethazine. They have both sedative as well as anticholinergic action, and so they produce relief of cough and the patient is able to sleep well. Other adjuvants include bronchodilators. Bronchospasm or stimulation of pulmonary receptors can induce or aggravate cough and also cause bronchoconstriction. And so, for example, beta-2 agonists, which are bronchodilators like salbutamol and terbutamine, are sometimes used for relief of cough used by bronchospasm. So what is the mechanism of bronchodilators in cough? The surface velocity of airflow during cough, and then clear the secretions of the airway. They increase the surface velocity and clear the secretions of the airway. They are not routinely used for every type of cough, but when bronchoconstriction along with cough is present, then you can use bronchodilators. There are certain neuromodulators which can be used for cough. For example, gamma aminobutyric acid analogues that inhibit neurotransmission has been used. They are beneficial in chronic idiopathic cough, which also involves neural hypersensitivity. For example, gabapentin and pregabalin has been used to suppress cough, which involves neural hypersensitivity, like cough as a result of idiopathic cough as a result of neural hypersensitivity. And so gabapentin and pregabalin has been tried. The other drugs examples, newer drugs include moixigine. They act peripherally and appears to open the ATP sensitive potassium channels. Theobromine is another naturally occurring methylgentine. It reduces cough induced by tussive agents or drugs which causes cough. Some novel antitussive agents include transient receptor potential antagonists. Transient receptor potential or TRP ion channels are present on the airway sensory nerves. They are called TRP ion channels or transient receptor potential ion channels. They are activated by stimulants like capsaicin, hydrogen ion, histamine and bradykinin. The transient receptor potential V1 and PA antagonists are potential antitussives in development. The ATP receptor antagonists, like ATP is a tussive agent in patients with asthma and COPD by activation of P2X3 receptors on the afferent nerve. And ATP has been postulated to, this receptor antagonist has been postulated to be effective in chronic idiopathic cough. So, ATP receptor antagonists are also being tried. So, what are the treatment approaches for cough? Whenever possible, you have to treat the underlying cause and not the cough, because cough is a symptom of many other diseases. For example, if the cause is upper respiratory tract infections or viral infections, normally it is self-limiting and usually requires, but if it is viral, it requires no treatment. Upper or lower respiratory tract bacterial infections, for this you have to give the appropriate antibiotics as well to treat the bacterial infections. In case of chronic bronchitis or bronchiectasis, cough due to this, then cessation of smoking which causes bronchiectasis, avoidance of pollutants, steam inhalation and postural drainage should also be tried in case of chronic bronchiectasis or bronchitis or bronchiectasis patients. In case of asthmatic cough, you have to have the treatment for asthma like beta-2 agonists or corticosteroids. In case of pulmonary tuberculosis, cough because of pulmonary tuberculosis, you have to treat the patients with anti-tubercular drugs. ACE inhibitor associated cough, you have to think of lowering the dose of the angiotensin converting enzyme inhibitors, or you can substitute with angiotensin receptor blockers which do not have cough as a side effect. And in case of gastroesophageal reflux diseases which causes cough, then you can think of giving the patient H2 receptor antagonists or proton pump inhibitors. So, you have to treat the underlying cause of the cough as well, not only the symptomatic relief of cough. So, you have to see what is the cause of cough in that particular patient, and depending on the cause, you have to give certain specific drugs as well in case of different patients. So, it is nice to advise the patient to cover his or her cough. So, you should not share your germs, you should cover your cough and sneezes with tissues and throw away your dirty tissues, and if possible the patient should be advised to cough into his or her elbow. So, other important measures apart from the cough medications include steam inhalation. Patient should be advised adequate hydration because it clears the mucus. Warm fluids should be taken by the patient, non-exposure to cold, and it has been seen that in case of upper respiratory tract infections, the vitamin C, antioxidants like vitamin C and E has been reported to help. So, these are some of the important measures apart from the specific cough medication. You have to advise along with the cough medication, you can ask the patient for steam inhalation, adequate hydration, keep taking warm fluids, non-exposure to cold, and vitamin C and E. So, this was about the cough, drugs used for cough. Thank you very much.